Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. The new COVID vaccine has been approved, and for help understanding who needs to consider the updated shots, I'm talking with Dr. Stephen Thomas. He is director of the Upstate Global Health Institute and a professor of microbiology and immunology who specializes in infectious disease at Upstate. Welcome back to The Informed Patient, Dr. Thomas.
Thanks, Amber.
We're coming up on the sixth anniversary of the COVID pandemic. What can you tell us about the evolution of the virus that started all this?
Well, it's hard to believe it's been 6 years, but it has been. Viruses in general, they want to mutate. They like to mutate. They're trying to find that good balance between their environment and the host and their longevity. And that's what this virus has done. But what seems to be happening is that maybe there's a hint that the frequency with which the virus is mutating significantly, and what I mean by significantly is the virus has changed so much that it has impacted the disease that people may experience, or it has mutated in a way that helps it to really evade the immunity that we develop, either through natural infection or through vaccination. The pace at which the virus has been doing that seems to have, I think, slowed a bit. It seems over the last year or so, which is, of course, good news because it means that the vaccines that people elect to take have a better chance of their beneficial effects persisting over time. So yes, the virus is still mutating, but it seems, at least to me, to be doing so less quickly, and that's overall good news for us.
Do scientists look at COVID as like the seasonal flu virus now?
That is actually up for debate. You have some folks who look at certain measures and say that they think it is, and some who say the jury's still out and they don't think it is. I don't know. To me, it seems to be that there's this constant low-level basal amount of transmission that is occurring at all times. But then we seem to get these surges, one surge in summer and then another in the late fall and winter. Of course, when it happens depends on lots of factors, but geographically, it varies by the region you are in the country, whether you're in the West or the Southwest or the Northeast. So is it a truly seasonal thing like we see with flu, which is clearly kind of flu in winter? I don't know if it's that clear, but there certainly seems to be repetitive cycles year to year of when we see upticks in transmission and disease.
For how long are we liable to be dealing with the variants and the subvariants of SARS-CoV-2?
Theoretically, I guess there could be some balance that is ultimately achieved between some variant and the human population, but I don't think that's going to happen. Like influenza, as we know, every year we go through a process of selecting what strains should be in the annual influenza vaccination, and that's been going on forever. And I have a feeling that that's going to be the same scenario for SARS-CoV-2, at least for the near future, but probably the distant future as well.
How quickly do those variants form? Could you have one in the summer and then a different one by that fall? Does it happen that quickly?
Over the 6 years we've been dealing with this thing, at some points in time, it has happened very, very quickly. Not even years, but quarters, months, there have been changes. There are just so many factors that can drive the development and sustainment of a new variant that it really is difficult to predict the timeline on which that would happen. The things that drive the development of variants is one of the major factors is the number of people getting infected, right? So the number of people that are getting infected and having replication of that virus and the tens of millions of copies of that virus, there's increased chance for error, right? When you just consider the numbers. Someone asked me about it, and I said, well, it's like, when I was in school and I got in trouble and I would have to write, I will not talk during class on the board 100 times. I was pretty good for the first 50 times. But then after I started getting into 60, 70, 80, I started spelling words wrong. I'd leave out a punctuation. I wouldn't capitalize something. So it's the same thing in a way with viruses, where the more they replicate, the more opportunity there is to mutate. And at some point, one of those new mutations is going to stick and infect the next person and take off with its own identity.
But do we have more than one variant circulating at a time then?
Oh, sure. We do. We do. And the CDC has a pretty nice, it's not updated as frequently as it used to be. And the amount of data going in there is not as robust as it used to be. But they have a great website that you can go to, and you can look at all the different variants that have been isolated from patients around the country. And there's some websites that can talk about it from around the world, like the World Health Organization. And they can tell you the frequency with which they're being isolated. So you can think of it as like a pie in a way, and they'll be able to give you a snapshot of how big the different pieces of the pie are. If each piece of the pie was a different mutant, it can give you those pieces. Usually there's one or two predominant mutants that are circulating in the country at any one particular time.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Stephen Thomas, the director of Upstate's Global Health Institute, about the COVID vaccine. Now, COVID vaccines used to be for anyone 6 months or older. Why did those government recommendations change?
A lot of people are asking that question. Typically, there is a process, right? There's a process where the FDA and its advisory boards are receiving information and receiving data from the manufacturers of the vaccines and the studies that they're doing. They're receiving data from the CDC and the networks that it has to collect data and information. It could receive data from maybe academic third parties that are involved in very large research projects that could inform these recommendations. And the FDA is supposed to make a determination about the safety and effectiveness of the vaccines. And then the CDC and its advisory bodies weigh in and talk about how those vaccines should be used and to whom they should be made available. And what flows from that is how any group that administers vaccines, like pharmacies or clinics or urgent care centers or things of that nature, or even employers for that matter, that they get their guidance from all of the new policies that come out from that process. But with this administration and this secretary, it's been a different process, and the committees have been changed and everything's much different than it used to be. And it's a little bit of, I think, an unknown to people like me that are not in those inner circles. It's been confusing and somewhat opaque and not clear how these decisions are necessarily being made. Usually there's pretty good alignment between the career scientists and the career experts at the FDA and the CDC, the advisory groups, and then the leadership of those organizations, and also agreement with the medical specialty societies that exist. So I'm an infectious disease doctor. I belong to the Infectious Disease Society of America, which about 90% of ID doctors belong to. OBGYNs belong to the American College of Obstetrics and Gynecologists, American Academy of Pediatrics, et cetera. You get the picture. They're filled with tens of thousands of physicians in particular specialties that have opinions on these and that inform these opinions. And they're also usually aligned. Not 100%. You don't want it to be 100%, right? Because it just means everyone's just agreeing with each other. And that's not the case, right? You want vigorous democratic debate, right? And deliberation. But that's not the case right now. There's misalignment between really FDA, CDC. They've got all new members on these external advisory boards, which some folks have concerns about the education, training, and experience of those people that are on those boards. And then you have specialty societies are coming out with their own recommendations. Kind of an unprecedented situation. So back to your question, how did we land where we landed? I don't really know. But that being said, the overall recommendation that everybody over 65 should be offered an opportunity to receive a COVID-19 vaccination, that is based in the idea that they are the group at highest risk of having a bad outcome if they get infected. And that's what the data has shown. It's the number one risk factor of having a bad outcome is your age. And over 65 is kind of a cutoff. Bad outcome, you've been hearing me talk about this for 6 years, but bad outcome means you're going to get sick, you're going to get really sick and may have to go to the doctor, be admitted to the hospital, end up in intensive care unit, and possibly end up in the morgue. That's what I mean by a bad outcome. And I don't think anyone would disagree with the fact that people over 65 should be offered that opportunity. It's the other groups, 64 and younger, who don't have pre-existing conditions that place them at increased risk. It's the kids under 2 years of age. It's pregnant women. This is where we start getting into real vigorous debate and disagreement and argument about who should be given the opportunity and who should not be given the opportunity to be vaccinated if they choose to do so. So, long answer to your question, but it was a highly complex question that required a lot of unpacking.
Well, how do the recommendations in the US now compare with those from other health groups in other countries or with the World Health Organization?
It's somewhat of a moving target in terms of where we are compared to others. But in general, and I think this is one of the reasons or part of the rationale for changing our recommendations, was to make them more aligned with recommendations for different countries and different regions around the world. It's kind of nuanced. So for example, people may say, well, okay, anyone under 64 can't get vaccinated then in the United States? No, that's not the case. They say if people have a condition which place them at increased risk for a bad outcome, they can get vaccinated. Okay, well, what are those conditions? Well, the CDC determines what those conditions are. Okay, well, if you go to the CDC's website and look up those conditions, there's over 20 of them, right? I think 23 was the last count. And some of them are very specific diseases like diabetes, for example, or different types of chronic kidney disease or reactive airway disease, asthma, for example, or COPD. But then there's some that are a little less specific. So obesity, and then they give a number to try to quantify what that looks like. Physical inactivity is another one, and a current or former smoker. So there's a lot of conditions there which would make you eligible. For kids, for children, they say kids who have immunocompromising conditions or compromised immune systems, they can be eligible. But then they also say that anybody who discusses with their doctor and participates in shared decision-making with their doctor, they could also be vaccinated if they want. So it sounds like it's kind of wide open. The problem is it's an access issue. Most people go to pharmacies to get vaccinated, and that process isn't going to occur there. So are they going to require some kind of prescription? Are they going to require just a personal attestation that, yes, I'm physically inactive, so please vaccinate me? What's the level of proof that they're going to require? I mean, it's very difficult to get in to see your primary care doctor. How are people going to get prescriptions? Is this going to be something they're doing online, telemedicine? How's that going to happen? And who's going to pay for it, right? I mean, if the insurance companies say, well, if the federal government is saying that these people don't have to be vaccinated, then maybe we don't have to pay for it. I'm just throwing out speculative questions here. But I think this is the difference that people are honing in on, is the opportunity and the accessibility by these new recommendations, and whether or not that's part of a larger scheme aimed at just vaccines in general and to make them less available.
Back when we first got the COVID vaccine, healthcare workers were included. I think they were at the top of the list of people who needed to be vaccinated, but that's not a reason to get a vaccine now. Do you agree with that?
I have not been able to find how that fits into policy anymore. But when you say a reason to get vaccinated, I could make an argument that first responders and medical professionals, there are reasons why they should consider getting vaccinated. Even if it's not mentioned in policy, I still think by the nature of their job, their risks because of their job, and the oath that they took and the commitment that they've taken to try and keep their patients safe, I think there's still a discussion to be had as to why that might be a good decision to make.
So these guidelines are very confusing for people. What are we supposed to do?
That's the $64 million question. I have not changed my opinion in the 6 years we've been doing this, that I believe getting vaccinated or choosing to be vaccinated or choosing for someone in your family to be vaccinated, that is a personal choice. But that choice needs to be based on accurate and high quality data and information. And that's kind of the rub, right? Because where to find objective data that is not buried in some kind of ulterior motive or ideology or whatever it is. I have always personally looked at multiple sources of information and then sort of found what the agreed upon trends were. And I look at New York State Department of Health information. I look at what comes out of the CDC. I look at what comes out of the FDA, and that's all publicly available stuff. Where I'm starting to shift a little bit because of what has been occurring at these health agencies and the curiosity I have around that, I have started to look now at the Medical Specialty Society recommendations. Normally, I mean, in the past, there's always been an alignment, right? But now there is not an alignment. And so I look to the specialty societies now, and I'm placing a lot of weight on what obstetricians and gynecologists are recommending for pregnant women, right? I'm looking at what pediatricians and pediatric infectious diseases physicians and allergists and immunologists are recommending as it relates to kids getting vaccinated. So that is a new source of information that I'm going to, and I'm encouraging others to go to, because that's also publicly available. And that's what I would encourage people to do, is to get access to, again, unbiased, objective, data-driven, science-driven recommendations so that they can make a decision about what is best for them and best for their family. Now, you'll hear folks say that, oh, those organizations somehow are not objective because they have advertisements for pharmaceutical companies or things of that nature. I personally think that's hand waving, just trying to be a distraction. And I still think that they're highly credible and they're making decisions based on what they believe is best for their patients. So that, I think, would be the only change this year, is I start looking to specialty societies and to see what they are recommending.
Don't you imagine people going to their primary care doctors are going to be asking them for their ideas too?
I think so. And again, the vast majority of physicians belong to their specialty society. When we talk about people who are against vaccines, who fall into the anti-vax group, that's a really, really small percentage of people. If you're looking nationally, right? They're really, really tiny, but they're loud and they're coordinated and they're railing against things, right? If you look at the people who are vaccine hesitant, so I look at that as people who have legitimate questions that they want to have answered. That's also a very, very small group. I mean, the vast, vast majority of people believe in germ theory. They believe germs make you sick, and they believe that vaccines are a useful tool to try to mitigate the risk of those germs. The same is true for physicians and people in science, right? I mean, the vast majority of physicians believe in vaccines and believe in their benefit. But there are some folks, and I talked to them, I would get very nice emails from folks saying that the whole COVID-19 thing is fabricated in some way and the vaccines are dangerous and these kinds of things. So I think you should speak to your physician. And if they have a different opinion than what you have found in your research, right, or what you have found online, then I would ask them to explain why. And I would ask them to give you the evidence as to why they have a different opinion than what their society is recommending. Because in the end, it all comes down to, you should have a trusted relationship with the person that is helping you to make medical decisions for yourself and your family. And you should be able to have a conversation, and they should be able to explain to you why they are recommending something specific for you. And especially if it seems to go against what the vast majority of experts in that field are recommending, they should be able to explain it to you so that you can make your own decision. So that's how I look at it.
And your society is the Infectious Disease Society of America?
That's one of them, yeah.
And just so listeners have it, it's idsociety.org for their website. This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Stephen Thomas, the director of Upstate's Global Health Institute, about the COVID vaccine. Do infectious disease doctors worry about what's going to happen if people don't have access to the COVID vaccine and don't get vaccinated? Are we liable to see another pandemic or a continuation of the last one?
I think ID doctors and epidemiologists and anybody who thinks about medicine or science or public health or global health, health security, all these kinds of things, I think anybody who thinks about those concepts and topics do worry. Could there be a repeat of what we saw with COVID? Could we have another influenza pandemic? Even a minor one like in 2009, right? These things can create big hiccups, even if they're just regional, right? I mean, think about the Ebola outbreak in West Africa. I mean, that created a lot of trouble and it was very well defined geographically, but it created a huge issue globally, right? For lots of different reasons, because we're all so connected. Same thing with the Zika outbreak that we had around 2015, 2016 or so, which again was largely regional in nature, but still had ripples throughout the world. So I just think in general, people are always concerned about emerging and reemerging infectious diseases. And I think it gets compounded when there are tools that could help to mitigate the risk, and those tools are not being utilized, or there is misinformation or disinformation about those tools, or expectations are not being managed around the risk and benefit of those tools. That adds to it. That's a relatively new element. That's not something we typically think of having to deal with. We think primarily we got to deal with the pathogen and how it's transmitted and who's going to get sick and how can we keep them well and keep them alive. And now there's a whole other element that has to be considered, which is relatively new.
So let's talk about timing for the vaccine or the booster. Do people who had COVID have immunity from getting it again? Do they still need to consider a vaccine?
If you look at the studies, it would seem that hybrid immunity, what I mean by that is people who have been naturally infected, which is a lot of us, and vaccination, those two together seem to provide a combination of the best short-term immunity. We haven't really figured out the human immune system yet, and there's lots of people working on it all the time. And so we don't completely understand how it works, how it provides benefit in both the short term and the long term. It is not this qualitative thing, meaning if I'm immune, then I'm not going to get infected or I'm not going to get sick. No, for everyone, it's a little bit different. And immunity might mean you could still be infected, but you're not going to get sick. Or it might mean you'll still get infected and you'll get sick, but you're not going to get severely ill. The whole point is to try to keep people well enough so that they don't end up in the hospital and they don't end up dead. That's what we're trying to achieve with vaccines. And I think that people need to understand that that should be the expectation. Their expectations should be managed, I think, in that way. So yes, people who get infected should still consider getting vaccinated. There should be a period of time, 30 to 90 days, between recovering from your infection and getting vaccinated. And why would you want to do that? Well, because of what we already talked about. Viruses mutate, they change. And if you got infected last year with last year's flavor of SARS-CoV-2, you might not be protected against the flavor that's circulating this year. And vaccines provide you an opportunity to do your best to match your immunity with what is circulating in the community at this time as closely as possible. The other reason is not all infections are created equal, meaning you and I could both be infected, but your immune response could be different than mine. And I could have a less robust immune response than you, which means I'm now at greater risk. And getting vaccinated tries to level the playing field for everybody. And so there are reasons that people should consider getting vaccinated.
So at this point, we should look for a booster every fall like we do for flu shots?
It's a process. And I thought for a while there, the process was looking like it was going to be similar to what we do for influenza, where they start looking in the first quarter of the calendar year at the data. And by the second quarter of the calendar year, committees have met and have made decisions and have made selections, and manufacturers have embarked on making the new updated formulations. I have no idea what's going to happen, at least in the United States. I don't know how the process is going to proceed. I mean, this year we saw some variance from what we thought it was going to be. So I can't predict what's going to happen. But what I do feel comfortable saying is that I do believe every year there's going to be some discussion in the first or second quarter of the year about what we're seeing and what we're predicting will happen for that upcoming season. I think they're primarily targeted on the surges that we see in the late fall and the winter. So that's kind of what I'm thinking. But again, I cannot predict what the government is going to do.
Well, if they're both available, is it safe for people to get the COVID shot and the flu shot at the same time?
Yes, those studies have been done. And there's actually logistic reasons to do it. It's easier, one shot in one arm, one shot in the other. That's how I typically play it every fall, just because I just don't have a ton of time to be running back and forth. Again, we'll see with access to COVID vaccines how that plays out this year. But yes, there's no difference in how well the vaccines are tolerated if you administer them at the same time. And there does not seem to be any difference in terms of the immune response that you receive from each vaccine if they're administered at the same time.
Well, I want to thank you for making time to tell us all about this. Thank you, Dr. Thomas.
Thank you for having me. I appreciate it.
My guest has been Dr. Stephen Thomas, director of the Upstate Global Health Institute and a professor of microbiology and immunology who specializes in infectious disease. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.